And good morning. I'm Dr. Kim Allen Williams, Chair of Medicine here at the University of Louisville. And it's my pleasure to introduce our introducer. We are going to have a marvelous pulmonary-centric grand rounds given by Dr. Umair Gauhar. He is an associate professor of medicine and co-director of our interventional pulmonary program at UofL here. And he will be speaking on overview of parapneumonic effusion and empyema. And our introducer today is one of our incredibly talented and productive lung pathology or lung pulmonology critical care docs, Dr. Hiram Rivas Perez. He's been at UofL for quite a while, originally from University of Puerto Rico, and came to us after his fellowship at Ohio State University. And he is an assistant professor of medicine. And Dr. Rivas Perez, I'm turning it over to you.
Thank you, Dr. Williams. Good morning, everyone. It's my pleasure to introduce Dr. Umair Gauhar. I've known Umair for over 13, 14 years. Umair did his residency, internal medicine residency at the University of Alabama in Birmingham, followed by a fellowship in pulmonary critical care. Excuse me. After completing his fellowship, he stayed on at UAB as faculty for a couple of years, and then he decided to go to The Ohio State University to do his IP fellowship. This is where I trained and with him at OSU. And then he joined us in 2013 and to become the interventional pulmonary director of our program. He has been done a lot of scholarly work in lung cancer, lung nodules, and I've been able to collaborate with him in several trials involving advanced COPD and invasive therapies, including endobronchial valves and denervation therapies for patients with COPD and frequent exacerbations. During our trial in the endobronchial valves, we were the second highest enroller in the country, and we currently have one of the most busiest programs in the nearby states here. He is currently our IP director. He has very busy programs at University Hospital, the VA Hospital, and then Jewish Hospital. He was a person, he probably doesn't remember this. He taught me how to do my first chest tube when I was a first-year fellow. So I can attest that he's been a good teacher to our fellows, and he's won awards about his teaching abilities. Today, he's going to talk to us about parapneumonic effusions and empyema.
Okay, well, thank you, everyone, and good morning. I think I realized that this may be the last grand rounds for this year. So I wanted to make it not too heavy in data, but interesting to all levels of training and experience. Today, we're going to talk about parapneumonic effusion and empyema. It's a very common problem that we deal with, and often a complicated problem where the exact path of management is not always clear. So I'm going to have Jason scroll my slides. So Jason, can you go to the next slide? So when we talk about empyema, one of the things I realize is that there's a lot of dogma associated with empyema and parapneumonic effusions. The great Dr. Osler is quoted to have said that empyema needs a surgeon and 3 inches of cold steel instead of a fool of a physician. So he made his opinions very clear. And throughout this slide presentation, we will see if his ideas were right. And if he were alive today, are we in a better position to agree with him, disagree with him, or argue with him? Moving forward, next slide, please. We have 2 great giants in the field of pleural disease, Dr. Stephen Son and Dr. Richard Light. They were both contemporaries. And much of the knowledge of pleural disease, pleural infections, much of the knowledge about management comes from their ideas and their work. And together, they coined the famous term. Can we go to the next slide? The famous term that the sun should never set on a parapneumonic effusion, which most of us grew up with. And I think we still hold this saying near and dear. And oftentimes in our clinical practice, when we are encountering a parapneumonic effusion, there's a sense of urgency to at least drain it, do a diagnostic thoracentesis. And this saying is always alive in the background. So let's just go forward and talk a little bit about how common this problem is. And I think these numbers are probably an understatement. We know that parapneumonic effusion, as the name implies, is a pleural effusion that develops in context of a pneumonia. The annual incidence is quoted to be about 80,000 in USA and UK, but I think the actual incidence is probably much higher, especially in today's day and age of IV drug use. A lot of patients come in with septic embolism, necrotizing pneumonia, or aspiration pneumonia from substance use, and that often leads to parapneumonic effusions and empyema. About 50% of the patients who have pneumonia will develop a parapneumonic effusion. So that's an important number for us to remember. It doesn't necessarily mean that all these effusions require intervention, but a pleural effusion is a fairly common problem in cases of pneumonia. Complicated parapneumonic effusions, as we will discuss and describe in the next few slides, they can develop in about 10 to 15% of the patients. And empyema, defined as presence of pus in the pleural space, develops in about 5% of the patients, but it increases the mortality tremendously to about 20%. So a serious problem that we often get to see on the floors and in the ICU here as well. Our next slide, please. So when it comes to the pathophysiology of parapneumonic effusions and empyema, this timeline is important. The first phase, which lasts for about 72 hours, is the exudative phase. Then it leads to the fibrinopurulent phase, where there is pouring of collagenous material in the pleural space that lasts for about a week or so. And then it leads to organization, where there's progressive fibrosis in the pleural space. Now, why is this important? Because we can consider treatments that are designed to treat pleural space infection. And as you can see, the earlier you intervene, the better the chances of clearing out the pleural space. Once the pleural space starts to become filled with thick gelatinous material or fibrosis, most of the interventions that are available to the physician are going to be not helpful. This next statement that I have on this slide is very important for all clinicians who are managing pneumonia, who are managing pleural effusions, particularly our trainees and medical students, that clinical deterioration of a patient who is undergoing treatment for pneumonia with appropriate medical therapy, if that patient deteriorates on appropriate therapy, and the deterioration could be respiratory, hemodynamic, or constitutional symptoms, it should prompt investigation for a development of a parapneumonic effusion. So let's go to the next slide. So for example, here's a patient that we recently saw on the floor, came in with septic embolism and MSSA bacteremia. As you can see on the first slide on day one, you have multiple areas of septic emboli with some necrosis. Most of them tend to be just underneath the pleura. And because of the intense necrosis and inflammation, they often eat into the pleural space and lead to a complicated pleural process. So on day 5, despite appropriate medical therapy, the patient had worsening respiratory status, and we repeated a CT scan, and you can see that the very same septic emboli have turned into cavitary lesions, and you have a fairly complicated multiloculated pleural effusion. So this is a classic example of a patient who is being treated appropriately, but despite that, he had clinical deterioration, and we found a complicated parapneumonic effusion. So something that's very important for us to keep in mind as we deal with these patients. Next slide, please. So I will use this case to help us go through the understanding and management of parapneumonic effusion and pleural space infections. There are some questions in there. If you want, you can answer in the chat box, or we can just keep going forward. So this is a typical case. We have a 65-year-old homeless male with history of alcoholism. He presents to the ER with 6 weeks of malaise, fatigue. He's lost 20 pounds. His appetite is poor. He reports progressive shortness of breath. On presentation, he's afebrile. His vital signs are otherwise stable. He looks very cachectic. His lab work shows that he's anemic and has leukocytosis of about 30,000, and most of these are neutrophils. Chest x-rays on the next slide. Let's go forward. Here's a chest x-ray. So he's got a big pleural effusion on the left side and a smaller one on the left. So next slide. So a typical question, this is probably a good question for our medical students and our interns. What is the next step in management? Would you do diuresis, start antibiotic therapy, bronchoscopy, CT chest, or chest ultrasound? Keeping in mind that if you ask this question to multiple people, you may have different answers, but certain options in there are probably not appropriate. So next slide, please. So the answer will be chest ultrasound, and I will explain in the next few slides why chest ultrasound is important. Let's go forward. So we go to a study that's now more than 2 decades old, and this is the time when chest ultrasound wasn't readily available to the clinicians. But this was a good prospective study, and what they were trying to find out is, can the appearance of a pleural effusion on ultrasound help us predict how this effusion is going to behave? And they had about 163 patients. These were patients who had empyema. They underwent thoracic ultrasound. And based on the ultrasonic pictures, they divided these pleural effusions into 2 broad categories. You had the septated type, which is the top left, and then you had 3 different types of non-septated effusions. On the top right, you see a plain anechoic effusion, which is very typical of most of the effusions that we see, benign or malignant. And then you have in the bottom right, you have the homogeneously echogenic. So looks a little thickened, almost looks like it has some sediment in it. And then in the bottom left, you have a pleural effusion that has complex internal echoes. So these are the 3 different types of non-septated pleural effusions. So let's go forward. So this is what they categorized these effusions with, and they wanted to see, do these 2 effusions act differently despite medical therapy? And the answer was yes. In 2024, soon to be 2025, I mean, this information now seems pretty obvious and intuitive, but back then when ultrasound wasn't readily available, when most of the clinicians were not trained to look at pleural effusions with ultrasound, this was a good proof of concept study. So the mean hospital stay was longer in patients who had septated effusion with a significant p-value, 35 days versus 27 days in non-septated effusion. Duration of diagnosis was not any different. Duration of chest tube drainage was significantly higher in people who had septated effusion, 2 weeks versus 1 week. More patients in the septated pleural effusion group required fibrinolytic therapy as well as surgical intervention. The mortality was unchanged. So not a big surprise today that if the effusion looks complicated on ultrasound, probably going to require more aggressive and more invested therapy. Let's go forward. Another few points about chest ultrasound, I always keep these numbers in mind because oftentimes people ask, why do you even need an ultrasound-guided thoracentesis when the effusion is so large? So there are now multiple studies that have shown that even in large pleural effusions that are being managed by clinicians who consider themselves experts in thoracentesis, ultrasound-guided thoracentesis reduces complications, particularly pneumothorax. In several studies, the rates went down from 29% to 0, 18% to 3. And even if the patients had a pneumothorax, less patients required chest tube. Now, these studies were done with real-time ultrasound-guided thoracentesis, just like when we put central lines. In some places, if the bedside ultrasound is not available, often the practice is to ask the ultrasound tech to come and put a little X on the chest, and then the clinicians come in and do their thoracentesis where the X is. That technique is really not the right way to do it, because we don't know in what position the patient was when this X was put on the body. So generally what we do is we keep the patient in the same position, do an ultrasound, mark the spot, and if the patient hasn't moved, then you're good to go with your thoracentesis. Let's go forward to the next slide. Look at some other studies that also show why ultrasound is important. Multiple studies have shown that ultrasound can help you in difficult thoracentesis. So in one study, fluid was obtained in up to 90% of the taps after an unsuccessful clinically guided thoracentesis. The next point is something that I always keep in mind and often talk to the residents about. In one of the studies, patients came in with a large pleural effusion. They were assessed by expert clinicians, and they were asked to identify the site of thoracentesis based on the clinical judgment. And then they were asked to go in and do the thoracentesis. If it ended up being a dry tap, the ultrasound probe was placed on that site, and they found that in up to 60% of those cases, the clinicians were going below the diaphragm. And these were clinicians who are experts in thoracentesis and management of pleural effusion. Ultrasound also increased the rate of accurate site selection by 26% in another study, and decreased potentially dangerous needle insertion by 10%. And the rate of thoracentesis associated pneumothorax in mechanically ventilated patients when using ultrasound was extremely low. So I generally quote about less than 5% incidence of pneumothorax to the patients. But I think in today's day and age, particularly in an academic medical center, ultrasound should be part and parcel of management of any pleural effusion. All right, so let's go forward. So in our patient, a chest ultrasound was performed that showed a large pleural effusion, and an ultrasound-guided thoracentesis was performed. And here's the fluid, this yellow-green fluid was aspirated. And so this is, again, a good question for our trainees and medical students. The question will be, what further tests will be needed to diagnose empyema? Should you check a cell count, a gram stain, pH, or a pleural fluid LDH or serum LDH ratio, or none of the above? So think of the question and maybe think of the answer. Maybe you can write it in the chat box. But let's go forward and see what the answer is. And the answer is none of the above. As we saw in one of the slides, the diagnosis of empyema only requires the presence of purulent material or pus in the pleural space. Once you aspirate something that looks like this, the diagnosis of empyema is made. You don't need anything else. All the other tests that are mentioned on this slide are important, and they help us manage the patient, help us determine prognosis and need for further interventions. But as far as the diagnosis is concerned, you diagnose empyema just by looking at it. So important point for our trainees that if you're doing a thoracentesis and you aspirate something like this, you should already start to think about the next several steps in management. Antibiotic therapy, whether patients are going to need a chest tube, surgical intervention, or other interventions. All right, let's go forward. A little slide about the microbiology of parapneumonic effusion. It's the usual culprits, the usual organisms that we encounter in management of pneumonia. Community-acquired organisms include Streptococcus species, Staph aureus, gram-negative aerobes, and above the diaphragm anaerobes, as I would call them. About 50% of the cases are from Streptococcus, and then you have a fair number of anaerobes as well. In the hospital, again, you have the nosocomial organisms such as MRSA, or MSSA, and then gram-negative organisms. It's important to know that when we do thoracentesis and send pleural fluid for cultures, always use a set of culture bottles in addition to the tubes. This one study that I've quoted here from 2011, it showed that inoculating pleural fluid into the blood culture bottles actually increases the sensitivity of finding the organism by 21%, as opposed to just sending the fluid. So again, make this a usual practice, and we do this in all the hospitals where we work. We always inoculate some pleural fluid into the blood culture bottles as well. All right, let's go forward. A little bit about the Light's criteria. Dr. Richard Light came up with this criteria in 1972. I think he was still a trainee back then, and now this criteria is well known and widely used. The ratio of pleural fluid protein to serum protein greater than 0.5, or ratio of pleural fluid LDH to serum LDH greater than 0.6, or pleural fluid LDH greater than 0.6, or 2/3 normal upper limit of serum. Any one of these identifies the pleural effusion as an exudate, and using this criteria, we often, can we go forward? We divide the pleural effusion into transudates, exudates, and pseudoexudates. And for the purpose of this presentation, we will be just focusing on the exudates, because almost all the time, the parapneumonic effusions and empyema for sure end up being exudates. So let's go forward. So here's a slide that shows that even though Dr. Light came up with this criteria in 1972, since then, multiple studies have tried to redefine or retest Dr. Light's criteria, and his criteria still continues to perform very well in terms of its sensitivity, specificity, accuracy, positive and negative predictive values. And as we all know, it's a very quick, cheap, and easy test, and it performs well. So why mess with success? So well done, good job, and thank you, Dr. Light. Let's go forward. So these are two important slides. Once we find that a patient has a parapneumonic effusion, we want to categorize them into uncomplicated, complicated, or empyema. This is from the American College of Chest Physician guidelines. So what I want to emphasize is, if we look at the separate columns, the way I look at pleural effusion is I want to first visualize the chest image, including the ultrasound, and see how much effusion there is and what it looks like under imaging. Is it simple, anechoic, or is it loculated? So that's one set of information. Then in the next column, you have the bacteriology. After we have drained the effusion, we want to know the gram stain and culture. And then the next column is the chemistries, particularly pH, glucose, and the LDH. So as you can see, as the effusion amount increases, or the effusion becomes more loculated on imaging, and as your bacteriology goes from negative gram stain and negative culture to positive gram stain and positive culture, and as the chemistries go from alkaline pleural fluid to acidemic and to a low glucose, the pleural effusions are essentially getting more and more complicated. And as they get more and more complicated, if you go towards the bottom right of this graph, you will see that they are going to require not just thoracentesis, but other forms of drainage and even surgical interventions. So rather than remembering all these different parts, I just try to visualize the amount and what it looks like on imaging, the microbiology, and the chemistries, and makes things a little bit simpler. So this is the American College of Chest Physician guidelines. If you go forward to next slide, we will see the British Thoracic Society guidelines, and they make things a little bit simpler. They just divide effusions into simple, complicated, and then empyema, which is presence of frank pus. And they also take into account your LDH. And as you know, pH, glucose, and LDH, they all represent metabolism in the pleural space. So if there is high metabolism, LDH is going to be high, glucose could be low, and then the pH could also be more acidemic. And as the effusion gets more and more complicated, you're going to require more interventions. So which one of these criteria is better? Let's go to the next slide. This one paper from 2006 actually compared the two. And the good thing for the clinicians was that they both performed equally well. If you look at the bottom part, the sensitivity, specificity, positive likelihood ratio, negative likelihood ratio, both of these criteria was similar. So it's not really what the criteria is, it's what it represents as to what's going on in the pleural space. So you can use either one of these criteria. Let's go forward. So in our patient, the patient had empyema, his cultures grew pneumococcus, and he was started on appropriate therapy. His leukocytosis went from 30,000 on presentation to 20,000. And by day 5, he had a chest tube that was in place and was still draining about 250 cc's of grossly purulent fluid in 24 hours. And the question will be, what is the next step? Obviously, he has shown some improvement, but here he is with a chest tube that's still draining. So should you continue current plan of care and just wait and see if he needs more time? Should you obtain a chest CT or consult pulmonary medicine if not already done? Should you consult thoracic surgery? Should you send cultures on the pleural fluid again to see if the organism is resistant? Should we initiate intra-pleural fibrinolytic therapy or change to a larger bore chest tube, or any of the options from 2, 3, 4, and 5? So I'll give you a few seconds to just in your mind think about it, because this is again a very common clinical scenario. An empyema patient who's under appropriate therapy has a chest tube that's draining. It's not clogged up, it hasn't stopped draining, but day 5 and he's still got a little bit of leukocytosis and a lot of pleural drainage. So let's go forward. So any of these options can be good, and I want to make a very important point in the next few slides based on this question. Let's go forward. So this is from our British Thoracic Society guidelines from 2010, and I've just put an asterisk to the most important place that early aggressive therapy, including surgical consultation, is what is highly recommended. The point is that if by day 5 to 7, perhaps earlier than day 5 to 7, but certainly by day 5 to 7, if with appropriate clinical therapy, including a chest tube, the patients have not improved to the point where discharge is in the picture, we cannot keep going with the same plan of care. We need to do something different. We need to escalate care. And escalation of care can be any of these options that we discussed. It could be doing another CT scan to see what the remaining fluid looks like. Has the fluid become so loculated that it's now walled off from the chest tube? Should we consult surgery to do surgical interventions? Should we consult interventional radiology to maybe place another pleural drain in a separate loculation? Should we consult infectious disease? So by day 5 or so, continuing with the same plan is probably not appropriate, and we should escalate care to the next level if there's continued signs of infection and pleural drainage. All right, let's go forward. So how do we treat these patients? Obviously, it depends on the microbiology. We need a broad spectrum antibiotic to begin with. So a 3rd generation cephalosporin or a beta-lactam like penicillin. And then if the effusion is related to a nosocomial infection, then you keep the nosocomial organisms in mind. A few important points that I want to make here is that in many of these situations, especially if the patient had an aspiration pneumonia to begin with, the infection is polymicrobial. Even if you have a positive culture, that culture may represent only the organism that's growing in the lab, but there could be other organisms, especially anaerobes. So treating anaerobic infection is important. Macrolides by themselves don't have much of a role in the treatment of parapneumonic effusions, but they do help in management of community-acquired pneumonia. And aminoglycosides are also not appropriate because they have poor penetration. How long do you treat these patients? It's somewhat uncertain, but generally the more complicated a respiratory infection is, the longer the treatment. So generally we treat these patients for about 2 to 4 weeks. All right, let's go forward. This is again a slide that I think is very intuitive. What are the prognostic indicators in parapneumonic effusion? And most of these make sense, if not all. So if you have frank pus, if the bacterial smears are positive, gram stain, if the glucose is less, if the cultures are positive, if the pH is less than 7.2, if the LDH is very high, or the pleural fluid is very loculated. So it sort of goes back to the ACCP and British Thoracic Society guidelines that the more complicated the effusion looks, the poorer the prognosis, the longer the treatment course, and perhaps more the interventions that the patient is going to need. Or let's go forward. As far as prognosis is concerned, recently in the last a decade or so, there's been a development of a prognostic score. It's called a rapid score to identify those patients who are at risk for poor outcome. So rapid score, just like the light criteria, is an easy to use score. I don't think it has caught on as much, but something that is very easy to use and can give us useful information and objective information about how these patients are going to behave with treatment. So the rapid score takes into account their renal function, and based on worsening renal function, there's an increasing score. Takes into account their age, the presence or absence of purulence, whether the infection is community-acquired or hospital-acquired. Also takes into account their nutritional status as determined by albumin, and gives them a certain score, which is classified then as low risk, medium risk, and high risk. Let's go forward. And this score was tested to identify long-term outcomes in pleural infections. And as you can see, the higher the score, the poorer the outcomes. And this is despite treatment. So I think at any time we have a way to put a number on our treatment or outcome, it at least helps the clinician, and sometimes also helps carry out conversations with patients and families. So this is something that it's easy to use, and I think we should be using it in order to understand, in some degree of objectivity, what the prognosis is for these patients. All right, let's go forward. Here's another study which looked prospectively to validate this rapid clinical score in patients with pleural infection. And using this score, they found that the mortality was about 10% at 3 months and 19% at 12 months. And the rapid score could predict mortality at 3 months based on low, medium, and high risk. The mortality could go from about 6% to about 14% to about 40%. And so again, the average mortality of empyema and complicated parapneumonic effusion is still around 20%. But in certain cases, as you can see, it can be even higher. All right, let's go forward. Okay, so I will shift from here and get into some of the more debated and hotly discussed topics in pleural space infection. Going back to the saying of Dr. Osler, who was obviously very confirmed in his mind that empyema needs a surgeon. Many decades later, we do have tools and therapies available to the clinician. So what's the best way to approach this? Obviously, in the pre-antibiotic era, the only way to approach empyema was to go in the chest and clean it out with whatever you could do. And as we go forward to the next slide, you'll see that this used to be one way, or perhaps the only way, that empyema used to be treated. This is what's called a Clerget window. So what you're seeing is the right chest, where a surgeon would go in, make a large thoracotomy scar, and then turn the skin over the scar to basically create this open wound, which will continuously drain to the outside. And they could just put a little bag on it and collect pus, just like an ostomy bag. And for many decades, this is how empyema was treated, because there was no other option. Let's go to the next slide. So here we have a group of young men from around the First World War era, when TB and TB-related empyema was probably very common. And as you can see, this is how it was treated. This is what life used to be for them, and there was no other option. But moving forward, now we have multiple ways to drain the pleural space. And this is the point that I want to make, that when we say pleural drainage, it doesn't necessarily mean a big chest tube anymore. We live in an era where we have multiple ways to drain the pleural space. So as you go to the top left, we have thoracentesis. If you perform a thoracentesis and you completely evacuate the pleural space and the pleural effusion does not return, well, you have accomplished pleural drainage. Then going to the next pigtail catheters, go back, please. So you have many different varieties of pigtail catheters that come with their own attachments and their own sizes. So we live in an era where there are several different options of pleural drains. Then you have many different options of chest tubes, ranging from small bore chest tubes to large bore chest tubes. Then in the top right, this bronchoscope looking instrument is a medical thoracoscopy equipment, also called a pleuroscope, which is something that we do over here under moderate sedation. So this can also help us enter the pleural space with video and drain the pleural space, break down adhesions, and place a pleural drain. And then you have two surgical options. You have VATS, video-assisted thoracoscopic surgery, and then you have open thoracotomy. So many different ways of doing pleural drainage, but different ways also bring different options and different questions, and sometimes different debates. So let's move forward. So one of the big debates that is there in the field of pleural space infection is, does a large bore chest tube perform better than a small bore chest tube? And I think in today's day and age, most clinicians, including surgeons, are now convinced that small bore chest tubes, if managed appropriately, perform just as well as large bore chest tubes. But occasionally you still find somebody who will debate and discuss this with you. So this is a study from 2010 where they compared many different sizes of chest tubes, from less than 10 French to 10 to 14 French, 15 to 20, and more than 20 French. And they compared death and surgery, death at 1 year, surgery at 1 year, hospital stay. And as you can see in the top part of this chart, that the outcomes were essentially unchanged. So small bore chest tubes, if managed appropriately, if flushed regularly, can perform just as well as large bore chest tubes, and a lot more comfortable for patients. And even now, the surgeons will actually prefer somewhat smaller bore chest tubes for these infections. So a certain paradigm shift in this field of pleural infusions. All right, let's go forward. What about intra-pleural fibrinolytic therapy, which has now become, in a way, a standard of care and a very well-known intervention for pleural space infections? This is the MIST-2 trial that brought this to limelight. There were 4 different arms: a placebo compared with combined TPA Dornase. TPA was 10 milligrams and DNase was 5 milligrams, BID times 3 days. So 1 dose every 12 hours for a total of 6 doses. They also compared it with DNase by itself and TPA by itself. And as you can see in this graph, that hospital stay, referred to surgery, and change in X-ray were all better in the combined TPA and DNase therapy. So that's the study that brought this to the management plan of these effusions, and now is performed very regularly. Let's go forward. Since then, there have been many studies looking at this treatment, and almost all of them have shown that the success rate with intra-pleural enzyme therapy is very successful. Success rates of 90% have been reported, and the bleeding rates are less than 5%. So the main complication of this, because of the fibrinolytic therapy, is usually hemothorax, but the rates are fairly small. I often tell the patients and the treating team that after doing TPA and DNase therapy, patients can have pain, they can have signs of inflammation in the form of fever, leukocytosis, and the fluid can often seem grossly bloody. That does not mean there's a complication. It just means, the medicine is working as predicted. All right, let's go forward. Now, as I said, because we have different options of treating pleural space infection, now we're getting into an area where people also have different questions and different opinions about what's the best route. Should we treat these patients with antibiotics, a pleural drain, followed by intrapleural TPA DNase, and then see if it fails and then refer to surgery, or should we refer to surgery early? And these are the questions of our times. This is a retrospective study of about 566 patients that tried to look into this question. And they compared early surgery versus intrapleural TPA and DNase therapy. Now, a point to be made that in this study, the TPA DNase therapy had all mix of doses and frequencies. So they had the MIST-2 type of dosing, and they also had a non-MIST-2 type of dosing. MIST-2 type of dosing means exactly how it was done in the MIST trial, and the non-MIST-2 dosing was either decreased doses or longer courses or shorter courses, so just based on clinicians' discretion. Treatment failure was defined as persistent infection with pleural fluid collection requiring further interventions, and crossovers were defined as surgery after fibrinolytic therapy or fibrinolytic therapy after surgery. So let's go forward. So what did they find? They found that in the surgery group, there was less need of additional treatment, less treatment failures, and less crossovers as compared to those patients who got fibrinolytic therapy early on. There was no difference in mortality at 30-day and 90-day between the two groups. When they look at this group, they found that if the patients got the fibrinolytic therapy according to the MIST-2 trial, then there was really no difference in the crossovers. It was 11 versus 6%. So it's a retrospective study. You cannot draw a lot of conclusions out of it. Overall, looks like it favored surgery, but it also brought out the point that if we are going to do fibrinolytic therapy, we should stick with the MIST-2 trial dosing and do it the way it was done in the real trial. Or let's go forward. So that brought this other trial, which is probably the only prospective trial that has looked at intrapleural enzyme therapy compared with VATS surgery. This is the MIST-3 trial. They had 60 randomized patients out of 97% eligible, and they were randomized 1:1:1 to intrapleural enzyme therapy according to the MIST-2 trial dosing, or the standard of care, which was antibiotics, chest tube that was often flushed with saline to keep it patent, versus VATS. And then these patients were followed for 2 weeks after randomization. So let's go to the next slide. What did they find? So they found that obviously getting surgery took a little bit longer, about 3.5 days compared to 1 day for the enzyme. Makes sense. It takes a little bit longer to get surgeons on board and find time in the OR, whereas you can do enzyme therapy day 1. There was no difference in the length of stay in the enzyme therapy group and surgery group when compared to the standard of care, 7 days versus 10 days. There was no difference in the readmission rates at 2 months, no difference in the reintervention rate. As far as pain scores are concerned, early on, and I was a little surprised to find that the patients who got enzyme therapy actually complained more of pain than those who got standard of care. And patients who got VATS actually complained less of pain, perhaps because they were being treated more aggressively for post-operative pain. But 2 months after, the VATS patients had more post-op pain or long-term pain compared to those who had gotten enzyme therapy. So again, probably somewhat intuitive that patients who have enzyme therapy, because there's a lot of inflammation and tissue breakdown that's induced by the medication, they can have pain early on, but still it's manageable. Or let's go forward. A few words about medical thoracoscopy. That's the bronchoscope-like equipment that I showed in one of the slides. We can perform medical thoracoscopy here at this hospital and also at the VA hospital. Can we do medical thoracoscopy as a nice in-between VATS and enzyme therapy? Because it can be done with moderate sedation. It's an outpatient procedure and doesn't require general anesthesia. It does not require lung ventilation. Well, the answer is not that clear, but there are some studies that are reassuring. Medical thoracoscopy shines when it comes to malignant or tuberculous effusions. In many parts of the world, tuberculosis is still a big healthcare problem. So medical thoracoscopy is very helpful in managing, diagnosing those patients. As far as parapneumonic effusions and empyemas, there are two studies. One, a retrospective study of 127 patients that included multi-loculated pneumonic effusion. And they showed a success rate of 91% and only 6% conversion to surgical intervention. And another study of 41 cases of empyema was treated with medical thoracoscopy, also called pleuroscopy, and had a good success rate. So can we make medical thoracoscopy a usual intervention in empyema? I think the data is not clear. But in certain cases of early empyema, where the adhesions are thin and fibrinous and can be easily broken down, and the patients do not require decortication, I think medical thoracoscopy is still a viable option and can help break down fluid and allow easy drainage. Let's go forward. So more options bring more questions. So one of the questions that I had was, if I'm asked to do medical thoracoscopy for a patient with pneumonic effusion versus intra-pleural fibrinolytic therapy, say this patient that we are talking about comes in, I put an ultrasound, and the patient has some loculations. What should I do? Should I put a chest tube and put intra-pleural fibrinolytic therapy, or should I just go ahead and do medical thoracoscopy? Because technically we can do both. So there's one prospective trial that I found that had only 32 patients, and it showed essentially no difference in most of the meaningful outcomes that we worry about in these patients, whether it's hospital stay, mortality, adverse events, or length of stay in the hospital. And there were no serious complications. So at least there's some signal that if we choose to do medical thoracoscopy for empyema or pneumonic effusion early in the course, it's not very unreasonable, and we may actually be able to avoid intra-pleural fibrinolytic therapy when it's small but significant risk of bleeding. Let's go forward. However, this is a case that we recently dealt with. If a patient ends up with something like this picture on the right, this is a patient who came in with pneumonic effusion, grew E. coli in the pleural space, had a chest tube placed with missed dosing of TPA and Dornase, and despite that, she was left with an unexpanded lung. As we can see on the CT scan to the right, the pleural space is very thickened. Parts of the lung haven't expanded. There's still a fluid and air fluid level. this is a situation where further TPA, further chest tubes, or medical thoracoscopy is not going to be helpful. This is a situation where the patient needs to undergo surgical intervention with debridement and decortication. And the only way to expand that lung will be for the surgeon to peel away that thick inflammatory peel. So if we have ended up with something of this sort after our appropriate interventions, then certainly we have to think about calling the surgeons if we had not called them earlier in the course. So can we go forward? So I will leave you with this last slide. When we take care of patients with parapneumonic effusion, there are many outcomes that we have in mind. Some of them are inflammatory markers like fever, leukocytosis, CRP, improvement in chest imaging. But really the more meaningful outcomes that we should be looking for and that should drive our clinical care and our research should be how long are the patients needing a chest tube and how long is the chest tube draining? Do they need further interventions? How long do they have to stay in the hospital? And mortality and surgical interventions. So the most important point that I want to leave you with is that if you have a patient with a pulmonary effusion who has a chest tube that's still draining, even if the patient has no fever, no white count, and the chest x-ray looks better, we have not achieved a meaningful outcome. And something else needs to be done. Consultants have to be involved or the therapy has to be escalated. Next slide, please. So to summarize what we have discussed, pulmonary effusions need to be recognized early. Early pleural fluid analysis needs to be done. Ultrasound should be part and parcel of management of these conditions. Broad spectrum antibiotic therapy, including coverage of anaerobes, is important. Pleural drainage is needed for empyema and complicated pulmonary effusion. Intra-pleural fibrinolytic therapy and DNase therapy is now widely recommended. Whether it should be done right away or a few days later is still a question that is not answered. And very importantly, if around day 5, patients are still not showing complete resolution, then therapy needs to be escalated. Next slide, please. So going back to our first slide, if Dr. Osler was to come back today and said what he said, that empyema needs a surgeon and 3 inches of cold steel instead of a fool of a physician, am I in a better position today to disagree with him, argue with him? I'm not sure if I am. I think the role of surgery is still very important, but I can tell Dr. Osler, the physicians of today are no longer fools. They have a lot of evidence to support what they do. And we have medical thoracoscopy and we have intrapleural fibrinolytic therapy, which can save the day in many of the conditions, many of the situations that used to require a surgeon. So we have certainly made a lot of progress in the management of these conditions. Let's go forward. So I will leave you with a few minutes to ask any questions. I hope I didn't bore you or didn't leave you with too much to grapple. Thank you very much.
Well, thank you so much, Dr. Gauhar. That was just an amazing, really incredible amount of information, and it's good to see that the field has developed a light. They've shown a lot more light than we had. No pun intended. Puns always intended. And we'll have an effusive number of questions in the chat, and I should turn it over to Dr. Rivas Perez. Oh, I see Dr. Arnold, our infectious disease chief, but looks like that's not really a question, Dr. Arnold.
I don't think there are any questions.
No, I'm fine.
Okay, sounds good.
I guess I've left them speechless, huh?
Yes.
Really a lot of information and great developments, and I really appreciate the fact that we have moved on so much. One concern that we would always have in the past is, well, was this a pneumonia that had some aspect of malignancy to it? And so there's probably no role for imaging techniques such as PET scanning, gallium, all the stuff that we used to do to try to distinguish infection from neoplasia. But some role for advanced imaging in that regard, or is it just so unusual?
Yeah, I think that's a very valid question. So yes, we do see patients who have underlying malignancies, either known or suspected, and then develop an infection. I don't think there's any role of PET scan or gallium scan right there and then. I think the best thing to do will be to clear out the infection and then repeat imaging. Having said that, in this situation, medical thoracoscopy can help us take pleural biopsies. And I can remember one patient that we treated at the VA many years ago who had this recurrent loculated effusion. And we finally did medical thoracoscopy. And underneath all the pleural peel and the adhesions, there was malignancy.
Oh, fantastic.
I do have a question, Dr. Williams. Is Dr. Saad?
Great. Good morning.
Good morning. Hi, Umair. I'm sorry I missed the first few minutes of the lecture, but it's the same thing that you mentioned in your talk about the debate about the size of the chest tube, and because we keep getting asked about this from the trainees, and I'm wondering about your preference. The old school, we used to put a bigger size chest tube for maybe hemo or empyema, smaller size for uncomplicated effusion. What's your preference? What's your size chest tube that you use, for example, for complicated or empyema?
So one of the problems with this kind of debate is that I don't think the community is still decided on what's a small bore versus a large bore. But having said that, most of the recent studies, if you have anything 18 French or somewhere around that time, around that gauge, it's good enough for even the most complicated empyema. The only situation where you could need something larger is if you have associated hemothorax. I will say this, however, that in almost all these studies, the standard of care required periodic flushing of the chest tubes with saline, which is something that we don't do frequently. So to answer your question, if you have a relatively small bore chest tube, but you keep it flushed and open with periodic flushing, it should perform just as well as a large bore chest tube with a lot less pain.
Great. Thank you.
And real quick, Dr. Gauhar, there's actually a question from Dr. Sarakbi in rheumatology. He wants to know, is management different in recurrent empyema?
It certainly will be. I mean, recurrent empyema would be a failure of initial management. One of the most common question that we will have to ask is, why is it recurring? Was it resistant organisms, or was it a loculated pocket that wasn't drained? Bronchoscopy does become important in those issues because some patients can have recurrent aspiration, aspirated foreign bodies, or in some situations, a bronchopleural fistula that wasn't diagnosed. So I think recurrent empyema will require its own set of management to understand why is it happening despite appropriate clinical therapy.
That looks like the only question in the chat area. So
I have a question. Umair, I have a question. A very common question I get with the fellows and the residents is, when we ultrasound somebody looks complicated, do we just go straight to chest tube or a thoracentesis for diagnostic purposes?
Yes.
What are your thoughts?
I'm glad you asked that question because I can tell you, I think we live in a time where we have a wide variety of pleural drains. We are not living in a time where there's just 32 French and 26 French. And I have started to, propose and even include this in my practice, that if I look at an effusion and it's complicated and the clinical scenario makes sense, and I think this is going to require some time and TPA, I will place a pleural drain these days you have 8, 12, 14 French pleural drains that are not much different from a thoracentesis catheter. Patients tolerate them very well, and I think I would just go straight to a, pleural drain, and then you can drain it and also do other therapies. So I've become pretty proactive about just going straight to a pleural drain.